Well, thank you. I really appreciate the chance to come back to the Summer Healthy Living series again, 3 years in a row. 2 years ago, I spoke about emerging infectious diseases. Tonight, I'm going to talk about opioids and methamphetamines. I think probably if you have a series called Stuff That'll Kill You, that may be a better place for me, but I hope that the information that I'm providing is useful for everyone to be able to live more healthily in the future. So what I'd like to cover tonight is 3 areas related to opioids and methamphetamine. Where are we? How did we get here? And where are we going? So let's start with where are we at? So this is a slide that represents opioid overdose mortality. So if we look at nationally, opioid overdose mortality, it is an issue that has evolved over the past 20 years. And I spend a fair bit of time working in epidemiology. I don't have a master's in public health, but sort of got my head around some basics of epidemiology. We use the word epidemic very broadly. I'm very careful in how I use the word epidemic. I really restrict it to when we're talking about a health event that has increased dramatically beyond historical norms. And in the case of the opioid crisis or epidemic, I'm very comfortable talking about epidemic because we've seen a 4-fold increase in deaths in our country over a 20-year period. And I think there really hasn't been anything with that profound of an effect on mortality in our country really since the emergence of HIV/AIDS in the 1980s, and before that really since the influenza pandemic, which was exactly 100 years ago this fall. So we actually had a disaster declaration for the opioid crisis in Alaska, and some people say, well, why a disaster declaration? The impact of the opioid crisis is definitely a threat to life and also a threat to property because there are criminal justice ramifications of opioid use as well. And if I could continue that natural disaster analogy, I think of it as almost 3 waves of a tsunami. Even though we're way inland, you guys feel the big earthquakes here also. So when I think of a natural disaster living a little closer to the ocean, I oftentimes think of a tsunami. The first wave is represented here by this kind of odd colored line that represents natural and semi-synthetic opioids. These are basically the prescription opioids. And you can see there was a fairly dramatic increase that occurred from the late 90s to about 2010. A second wave came in as well. Increases of death related to heroin with a fairly dramatic increase starting about 8 years ago. The third wave came in more recently with increases, what's labeled here as synthetic opioids other than methadone. This is fentanyl and some of the related compounds. So let's dig into that a little deeper in a few minutes, but first let's talk about the situation in Alaska. So looking at just sort of compressing the end of that slide down to the last few years, last 6 years from 2012 through 2017, we've not been spared. We've had a gradual uptick. If we went far enough back, we would see that there was a decline, and there really weren't that many opioid overdose deaths 20 years ago. If you're sort of an epi nerd like I am and are into rates, that translates for 2017, 100 Alaskans died. That's 13.6 deaths per 100,000. Put that into context, that's sort of middle of the pack for our nation. As you may be aware, West Virginia has some of the highest rates, and they're at about 52 per 100,000. The other measure, which I think is interesting, is what proportion of all deaths occur in our state are due to opioid overdose. It's right now about 1 in 30 deaths are related to an opioid overdose. So who are the people who are dying? And what are they dying of? So let's start with the type of opioids that are associated with deaths in Alaska. And it's important to realize that people who die oftentimes have more than one type of opioid on board. But if we look over the past 6 years again, when you see over the past couple of years, there's actually been some improvement in the rate of overdoses related to prescription opioids. In the past year, we actually saw a decline in heroin deaths. Unfortunately, while this is good news, this may not be good news. And a lot of these declines, or pretty much all of these declines, have been obliterated by the increase in deaths related to fentanyl and the associated compounds. Is this just a problem in Anchorage? Is it just a problem in Fairbanks? It is really a problem statewide. This map shows the rates by region. The more sparsely populated areas in the southwest and the north slope have too few numbers to really show that. But if we look at the rates in these bar graphs, you see it really doesn't vary by more than about twofold. The highest rates are in Anchorage and Mat-Su, but even here in the interior, which has slightly lower rates, it's not more than about twofold lower than other parts of the state. What I really wanted to call out is if we look at who is dying by age, half of these deaths are occurring among people under age 45. So if we consider the health impact of the opioid crisis, it really is comparable to alcohol if we think of it in terms of impact on premature death. Twice as many people die in Alaska of alcohol-related deaths. You have to say that right up front, that alcohol is also an important health issue. But opioids are killing people at a younger age than alcohol. I keep thinking I have the remote and I'm zapping the computer with the laser pointer. So it's more than just deaths. If we look at it also in terms of the number of emergency department visits, you can again see the variability across the state, but there's no part of the state that's completely spared. I oftentimes get the question if I'm traveling outside, what's unique about Alaska when it comes to the opioid crisis? And I like to say it's not unique. It is just like the rest of North America. There are some changes, though. You'll see some higher peaks about a year ago. So what's going on there? I'm going to keep asking questions. Let's talk about methamphetamine for a minute. Meth, some people think sort of went away. We don't hear about meth labs blowing up anymore. And while we still have home-cooked meth, we have now meth that's cooked outside and brought in. And much of this is coming in from outside of the United States. Some of it is crystal meth, some of it is liquid. One of the biggest busts that has occurred in international transit was actually 2 small bottles that were labeled vanilla extract. And they had literally thousands of doses of methamphetamine in liquid form in these 2 small bottles. We have seen over the past decade a pretty dramatic increase in the number of methamphetamine-associated deaths as well. Now, it's interesting that methamphetamine and opioid use are not mutually exclusive. While one is a kind of a downer, one's a stimulant, they are oftentimes used together. Sometimes it's intentional, called a speedball or a goofball, where somebody intentionally uses both simultaneously. Sometimes it's inadvertent, and I think that's important to recognize. And you can see the fingerprints of that in these data. This was data nationally that came from the National Survey on Drug Use and Health, a long-standing survey that assesses the health impacts of alcohol and drug use. And they chunked up the respondents into people who have no opioid use, people who only have used opioids according to a provider's prescription, those who have misused, those who have used outside of a prescribed regimen, those who have opioid use disorder. And this is where people start getting into problems with the law. There's a strict definition of what an opioid use disorder is. And then down at the far end, those who use heroin. So if you want to think of it as sort of a mutually exclusive categorization of increasingly dangerous opioid use, I think that's a good way to look at it. And you can see that with more dangerous use of opioids, there's also more self-reported use of methamphetamine, with about 15% of heroin users saying they also use methamphetamine. Now, remember that 15%, because if we look at the data in Alaska in terms of overdose deaths, we see that the number of heroin deaths is represented by the blue bars here. The proportion that involved methamphetamine is represented by the red line. And in 2017, nearly half of Alaskans who died with heroin or heroin metabolites on board also had detectable methamphetamine. That's a lot higher than 14%. So is Alaska really different? The difference, I believe, is that here we're talking about overdose deaths rather than self-reported use. And that what's happening increasingly is that methamphetamine is being contaminated with opioids. So it's not just people who are intentionally using both substances at once, but people are using methamphetamine that has been contaminated with fentanyl. So how does that happen? I am going to get to some answers at some point in all of this. So let's move into the how'd we get here. So let's start with just a quick primer on opioids. When I say opioid, I'm talking about all the molecules that do the function of opium, that they bind to receptors in the brain, specifically the mu receptors. There's also these receptors on the GI tract. That's why if you've ever taken an opioid for any length of time, you begin to get constipated. And in fact, that was used back in the days before we had antibiotics to treat dysentery, because opioids could be used to control diarrhea. It was been observed for millennia that it can treat pain, and it's probably still the best cough suppressant out there. So there are good and valid uses of opioids. But it was also noted early on that there was the potential for addiction, and that if you look really back centuries, there was description of people who were habitual opioid eaters. I think oftentimes they called them opium eaters, but it was opiate hunger is what was described. And it was also discovered that if you smoked it, you got into the bloodstream more quickly. So really for centuries, there's been the habits of taking opium or the derivatives by mouth or smoking them. In the 16th century, Paracelsus developed tincture of opium that we know as laudanum, which is still on the pharmacopoeia in the United States. The name came from Latin to praise. Early 19th century, German chemists distilled morphine from opium. It was named for Morpheus, the god of dreams. And also during the 19th century, a lot of opioid derivatives were developed, such as codeine and thebaine. And some of these are still used today. Now, because of the concern about opioid hunger, there was a physician in Scotland in the mid-19th century. At least the legend is he was observing how a bee stinger worked under the glass and decided, I wonder if you could deliver drugs as well as toxins that way. And he came up with what was really the prototype of the modern hypodermic syringe. And he wrote about how maybe if you could bypass the stomach, that would be a way to avoid opium hunger. Of course, that's not how it works. If you deliver it directly into the bloodstream, it actually is more addictive. And the sad irony is his wife actually died of an opium overdose from an injection. So we get to the end of the 19th century, we're talking about some real challenges with opioid addiction, and that's reflected in popular literature. If you've read the Sherlock Holmes series, there's the scene where Dr. Watson comes in and asks his friend, what is it today, Holmes, morphine or cocaine? And describes the syringe and its case on the mantelpiece. This is a painting that looks like it could be very 21st century, but it's actually from the 1890s. And it was of a Paris prostitute injecting herself with morphine, probably either intramuscularly or what's called skin popping, where you basically get it under the skin if you can't find a vein anymore. Right at the end of the 19th century, Bayer Pharmaceuticals developed a drug, diacetylmorphine, that received the name heroin from the German word for heroic. And heroic was because it was thought that this might be a formulation that would be less addictive, which unfortunately also was not the truth. Now let's fast forward about a century, and we're going to skip a lot of history here. You can tell I'm sort of a history buff. To 1996. Oxycontin was approved by the FDA. It was a form of oxycodone. Oxycodone was first developed in 1916 in Germany. It seems like there's a lot of German chemists that have contributed to the pharmaceutical industry. It was a time-released formulation. It was known that actually the slow release and the long half-life of methadone seemed to control the urges for excessive use of opium. So the thought was here you could get something that would be less addictive and also provide long-term pain relief. It was heavily marketed, primarily on its twice-a-day dosing. And there was a lot of direct-to-physician as well as direct-to-consumer marketing that made claims like there was no risk of withdrawal symptoms at up to 60 milligrams daily. Actually, we know now that that's the dose where you start getting into risk of overdose. 34,000 coupons for your free starter kit. You got your first month worth of oxycodone for free. And these were heavily marketed, especially to primary care physicians. Another thing that was happening at that time was the concept of pain management and a real push for pain as the fifth vital sign. And this was, I think, well-intentioned because through much of the 20th century, pain was undermanaged. And there was generally an avoidance of using particularly opioid-type medications. There was almost this concept that pain was good, and that, which is not entirely bogus, but it was undertreated in general by medicine in the United States and through much of the Western world. In the 90s, the American Pain Society promoted the concept of pain as the fifth vital sign. I'll bet everybody here, if you've been to a doctor in the past 20 years, at one point or another have been asked on a scale of 1 to 10, what's your level of pain? This is really problematic, and I think we sort of, in medicine, fell asleep at the switch on that because pain is not a vital sign. Pain is a subjective experience. You would walk right out of a provider's office if they ask you, on a scale of 1 to 10, what's your blood pressure today? That's not how we measure a vital sign. It is a numeric measure that can be quantitated. That same is true for heart rate, for respiratory rate, temperature. These are vital signs. Pain is a symptom and a subjective experience. And it also then became part of reimbursement for healthcare facilities because Joint Commission bought into this, the Centers for Medicare and Medicaid Services bought into this, oftentimes insurers did as well, and so it was considered quality of care if you had pain measures of 0. And I think many of us have had the experience of saying, well, my pain's about a 1, and somebody maybe really well-meaning, saying, well, fill this prescription, you might need it. And that was part of how, on the medical side, we got into problems with prescription opioids. Now, in 1980, there was a publication in the New England Journal of Medicine by Porter and Jick entitled, "Addiction Rare in Patients Treated with Narcotics." That was the foundation for a lot of how prescription opioids were used for a number of years. In 2001, there was a lot of information in the lay literature. In Time magazine, they had a title, a cover title on Less Pain, More Gain, and they cite Porter and Jick as a landmark study. And then they go on in that piece to say, many physicians now concede that patients have been under-medicated for decades, suffering needlessly. This is probably true. One reason was concern that big doses of opioids could depress respiration. This is also true. But a large part stemmed from an exaggerated fear that patients would become addicted. This fear, which continues to hold sway over American medicine, is basically unwarranted. This was what was being promoted out in the lay literature, places like Time Magazine, I'm sure many of the talk shows on TV. So let's look at that landmark study. This is it in its entirety. It was a 101-word letter to the editors of the New England Journal of Medicine. It wasn't a bad piece of work, but let's look at what it is. It's a review of some 40,000 patients hospitalized at Boston City Hospital, about a quarter of whom received some type of opioid during their hospitalization, and there was only 4 cases of reasonably well-documented addiction in patients who had no history of addiction. So, hospitalized patients, we're not even including people with a history of addiction. This is not everyone who comes in to the primary care physician with low back pain who's given a coupon for their first 30-day supply for free. But that's how it was marketed. And in fact, this is a screenshot from some direct-to-consumer marketing materials at the time, just to go along with that free kit, where this nice man tells you your doctor might prescribe an opioid medication. Less than 1% of patients become addicted. So that was really, I think, where in medicine we got off track and went the wrong way. And it was very heavily marketed. This is some of the swag from just one of the products. I have to admit, I had one of these clocks in my office at one time. I think I even had one of these little cool mugs that changes color. It has pain and turns to relief when you put a hot drink in it. But also some darker sides to it too, which only recently have really come to light. Not just giving coffee mugs, but really targeting high prescribers and doing everything that could be done to continue that. And I think the story that I thought was most impressive was the high prescriber that he was literally being stalked on social media by the pharmaceutical company that then realized, oh, he's recently divorced and he's on Tinder. So they hired a stripper to be their drug rep to be able to do the visits to him. So a lot of very manipulative and I think underhanded ways of promoting these drugs. So what happened? Not surprisingly, this slide may be a little hard to see, but it shows the per capita opioid prescriptions or consumption by nation. And you see far and away, the United States and Canada lead the pack and really declines as you get down to other countries with less aggressive marketing. The yellow line in this graph shows the deaths per 100,000 due to opioids. The green line shows the sales, and you see pretty much a mirroring. Now, what's not on this slide, which I would love to sort of make a new slide and put it on there, is the data from the Behavioral Risk Factor Surveillance Survey of the prevalence of chronic pain in the population. There was no change. In fact, if anything, it went up a little bit. So we were prescribing medicines to, quote, treat pain more appropriately, yet people were dying and there was really little evidence at the population level that there was less pain. So what happened there about 2010? A number of things began to reach a crisis point. First of all, a number of the manufacturers were getting into legal problems in terms of how they had promoted their drugs and how they had been marketed, including some pretty damning information showing that they knew some of the problems, yet they were really driven by the urge to sell more drug, particularly as it related to the twice-a-day dosing. That was a market niche, and when physicians were saying, well, Mrs. Smith's not getting relief with twice a day, it wasn't, well, maybe she needs to get it more frequently. It's, well, you just need to increase the dose. And that actually was part of the myth, is that you just need to increase the dose and everything will be fine. There also was more and more people who were becoming addicted. And it was different than drug crises in the past, because it wasn't just experimentation. It wasn't just meeting somebody at the Walmart parking lot. It was drugs that were being provided by a trusted provider. And so about 2010 was the time when agricultural practices in Mexico began to change. Heroin was nothing new, but opium poppies became the new cash crop in South western parts of Mexico. And suddenly, heroin wasn't coming out of Afghanistan and Turkey and going through Europe and being cut and through gangs on the East Coast and eventually hitting the West Coast, oftentimes in the form of black tar heroin. But now it was coming up directly. Much more pure, much more powerful, and a whole lot more cheaper. And there was a very ready market to receive this drug. And oftentimes people were beginning to get into trouble with their use. They were losing their jobs, losing their insurance. Their doctors didn't understand what was going on too often. I think providers' response was, you know, I took care of you for 20 years, but I'm not taking care of you anymore. So people were on the streets, and the only option was to use heroin. And if we look at the way heroin has been used over the past 50 years, there was a shift. Back in the 60s and 70s, there was a lot of heroin that was used. It was very expensive. If you've seen the French Connection, you know sort of that story. But most people were, quote, using the hard stuff. It was kind of a line at a time when people were experimenting with a lot of drugs. But heroin was really a powerful drug. As we get into the first part of the 20th century, we don't see such a large proportion of people whose first opioid is heroin. Rather, nearly at one point, 80% of people who are using heroin first started using opioids with prescription painkillers. That third wave I was mentioning was fentanyls, the friendly family of fentanyl killers. So you're familiar with fentanyl perhaps as a prescription drug that comes as a patch. What we're seeing now, there's some diversion of prescription fentanyl, but the bigger problem is illicit fentanyl that comes in the form of powders, mostly out of labs in China and in India, and it comes into the United States. And there's a lot of variations that have some type of organic chemistry prefix to fentanyl. Also things like U47700, I'm on a first numeral basis with it, U4, sometimes called pink. U stands for Upjohn. It was a pharmaceutical that was in development, but now has also come into the illicit market. And we've actually seen deaths associated with U4 in Alaska. The difference with fentanyl is that it's oftentimes cut into heroin, and sometimes it is contaminating drugs such as methamphetamine. So part of the concern with methamphetamines is a meth user may actually be opioid naive. They've never been exposed to it before and may get a big dose the first time they use that batch of meth that's contaminated. Fentanyl is very cheap also. So while heroin has certainly dropped in price, fentanyl is about 1/20th of the cost to produce. So, you know, if you're in that line of work and you've got this stable market and you've got this great cash cow giving you money and revenue, and you can provide the same product at 1/20th of the investment, you know, business practices are going to push you towards using more fentanyl. The other problem is counterfeit pills, and these are just a number of examples of what appears to be prescription opioid pills that are actually counterfeit pills that contain fentanyl. And these, for instance, these counterfeit generic oxycodones have shown up in Alaska also. So fentanyl is a game changer. Anytime you're using a drug from the streets, it's a game of Russian roulette. But with fentanyl out there now, there's more bullets in the chamber. So why are these pills so dangerous? You know, one of the challenges with these labs is there's no quality control. So if they're cooking meth, there may be fentanyl there as well. There's not a lot of care taken to not cross-contaminate. If you're making pills, you're basically taking the powders, mixing it with a matrix, pressing them together. I got to see some of the items that were recovered from someone who was busted. He actually had a single pill press and was pressing out pills one at a time using the vise in his garage. But you've got to mix the powder carefully. So it's basically the tablet matrix, the active substance, and if you don't mix them well, I call it the chocolate chip cookie phenomenon. And you get cookies with just a couple of chocolate chips, and then you get this guy that's loaded. So If you are talking about fentanyl now and you've used this pill, you didn't get the effect that you were anticipating, and you're feeling a little dope sick, I think I'm going to use 2, and if it's these 2, that puts you at high risk of an overdose. So just to summarize risk factors for overdose: higher doses, a recent increase in dose, co-use with other suppressant drugs like the benzodiazepines, things like Valium, excuse me. We're continuing to use after a period of abstinence, and I'll tell you a little more about how that works. So release from incarceration is a time of high risk, and of course use of illicit opioids. So what do we do? This is sort of how I think about it, and I'm going to go into a little more detail. I think the important take-home is to realize there is no solution. There are solutions. There's no magic bullet. There's maybe a magic shotgun shell, being Alaskans. It's going to take a multi-pronged and multi-sectoral approach to address this problem. So a little bit of what you see here includes what are the things that we do to save lives right now. People are dying. What can we do to save their life? Also, what can we do to treat addiction and to get people out of that situation of life-threatening risk? And then most importantly, how do we prevent people from using to begin with? And I'm sure I could spend the next 20 minutes going through this slide, but rather than doing that, I'd like to talk about some of the response that's occurred in communities across Alaska. So let's start with this highest level. How do we save lives by preventing overdose and also preventing the risk of infections like HIV? If anyone was here, I guess it was 3 years ago, talked about the HIV outbreak in Scott County, Indiana, where some 182 people became infected with HIV over a period of about 6 months in a town of only 4,000 people. Pretty remarkable event, all related to self-injection with prescription opioids and some related to heroin. So a lot of data, but I want to point out that data is people with the tears wiped away. So I want to also put in a few things that I've heard from people as I've gone around the state. This was from a woman in Sitka. We never used to see ambulances going down to the docks. Happens all the time now. We know what is happening, but nobody is talking about it. And I spoke to her afterwards and learned, unfortunately, she had lost her son to an overdose while he was out at sea. And I don't know if they sent an ambulance, but it was too late by the time the boat got back to port. So back in the back, we have the opioid rescue kits. This is something we've been able to do in Alaska thanks to a couple of things, a couple of laws that allowed a standing order for this prescription drug. And I'm actually going to show you what's in one of these kits. There's instructions in how to administer the drug. It is very simple. It's just a nasal spray, but call 911 because you're not, this is like doing CPR. You certainly are dealing with a life-threatening situation. There's a couple rubber gloves, and then 2 doses of prepackaged nasal spray. And that makes it very easy. There's nothing to draw up. You may have seen things on the news in other states where they're drawing up intravenous solutions and putting a sprayer on. This is actually much more concentrated. We have been able to purchase these thanks to some of the federal funding that's become available, but being in a fiscal crisis, we weren't sure quite how many evenings we were going to spend putting them together. But as we talked about the kits, there was a lot of interest in having volunteer events to put these together. So we learned a lot from that. I know there's an event coming up in Fairbanks sometime in the next couple of months. I don't think it's been scheduled yet, but watch the news for that. So we've been going around the state having events where volunteers can get together and put these kits together. This particular one in Wasilla, I think, was pretty moving because people came in oftentimes straight from work, and at one point in the evening, someone said, how many people would just care to share, don't raise your hand if you're not comfortable, but that you're alive today because somebody administered naloxone to you. And at least a third of the room raised their hands. And I thought it was really moving to see how many people are in recovery and are now in recovery because someone had administered naloxone. So while naloxone is not a cure for addiction, it is a tourniquet. It's a lifesaver. Gives a chance for someone to be able to enter into recovery. We've had these events. These are fun. This was actually a church group at my house in Anchorage. They wanted something to do that was social service, so we put together kits. The governor wasn't going to be outdone by me, so the very next week we had an event on the south porch of the governor's mansion. We scheduled this before we realized this was when the governor was going to be in China, so it kind of felt like, you know, being the teenager having a party while the parents were away. But it was really well hosted by the governor's mansion staff. And this is Karen Nelson in the middle of the picture here from Haven House. This is a residential facility for women coming into the community out of incarceration after drug charges. So the women of Haven House were a big part of that response. Another thing that can be done to prevent the life-threatening complications of self-injection drug use is syringe and needle exchange programs. There is really no data that these encourage drug use. I know, I have to say for myself, it took me a little while to get used to the idea, but I realized that while we were concerned about, you know, a bowl of Doritos being something that everybody's going to go buy and want to have one, people usually don't go buy a bowl of syringes and needles and say, I think I'll do a little heroin today. It's a different type of habit, and it's important to understand that it's not a habit, that it actually is a disease that drives behavior in a way that is very self-destructive. I think our biggest challenge with syringe and needle exchange programs is they're almost collapsing under their success. We still have federal restrictions on actually purchasing syringes and needles with this influx of federal funds, but at least those rules have loosened up enough that we can support the programs. We're fortunate in Alaska. I tell my colleagues in other states there's advantage of being in a red libertarian state. We've never had drug paraphernalia laws, so there's never been any restrictions on these programs. And sometimes we get dinged on these state-to-state comparisons because we haven't done anything to repeal our drug paraphernalia laws. And I'm like, we've never had any. So that's a good thing. Indiana, I think, learned it the hard way. It was, say 4 years ago, as a provider, I was caring for somebody who with a problem with addiction that led to self-injection drug use. If I provided needle and syringe, I could be looking at felony charges and up to 3 years in prison. The Secretary of Health at the time, who is overseeing the response to Scott County, recognized that was a problem. You may recognize his name, Jerome Adams, now our Surgeon General. He went to the governor of Indiana, Mike Pence, you may recognize his name also, and convinced Governor Pence that this was a problem. And Governor Pence issued an executive order to allow syringe and needle exchange programs in Indiana. And that helped bring the outbreak under control. Another thing that can be done is to assess fentanyl in drugs that are being used. And there's actually test strips that are available now. We're trying this as a pilot statewide, and community partners, including Interior AIDS Association here in Fairbanks, are looking at the possibility of providing these strips to users to be able to test what they're injecting so they can know whether or not there's fentanyl in it. But all of this doesn't cure addiction. So let's talk about how we treat addiction and also what addiction is. This is a photo from Candlelight Vigil in Wasilla this past winter. It is something that is becoming more prevalent statewide, and it's to honor the lives of people who have died of drug overdose and to call attention to the problem. It was about 10 below in Wasilla that night, which I know is a balmy night in Fairbanks, but we were joking it's really a burn barrel vigil and not a candlelight vigil. But it was really an uplifting time, despite the fact that we were there to honor people who are no longer with us. But one of the things that was said was by John Green, who you may recognize his name from the news, and talking about his daughter, Kelsey. When I'm speaking outside of Alaska, I kind of anonymized the story here, but basically he said, Kelsey told me a couple of months before she died, Dad, they tell you in school you can get addicted, but they don't tell you what addiction is. And so I think that's where we have to move beyond the old just say no to drugs. And I don't know if you remember the ads with the frying pan and the egg. I don't know how they were. I ate a lot of eggs. I looked at it, I thought, I like eggs. I wonder if I like drugs. But I don't know. So let's talk about what addiction is. It's important to distinguish addiction from tolerance or physical dependency. So tolerance is a predictable result of repeated administration of any opioid. If we all started one of those 30-day starter kits tonight, by the end of that 30 days, we're going to have some degree of tolerance and physical dependency. And when we stop, we're not going to feel good. And in fact, for some people, it can progress pretty rapidly to where you need a higher dose to achieve the same end. There can be symptoms of withdrawal that are variable. It's not uncommon for people coming out of post-op, if they've been taking their opioids regularly for a couple of weeks, to say, I don't feel very good. Man, I've been troubled with constipation, but I'm not now. And it's because those are some of the subtle manifestations of opioid withdrawal. So withdrawal, when it's full-blown, I like to say it's really wet. People sweat, they're nauseous, they're vomiting, they have diarrhea, tearing, runny nose. There's also a real rush of adrenaline, but not in a good way. It causes dilated pupils, the skin has goose flesh, heart rate goes up, blood pressure goes up, people become very agitated and anxious, and also it hurts, it's in pain. And this is one of the biggest clinical challenges I think we see now with people with chronic pain syndromes who've been taking opioids for a long time. It's hard to get the dose down. And it's very hard to know, is the pain they're experiencing the underlying disease that we're trying to treat to begin with, or is it manifestations of withdrawal because of the tolerance that occurs? It will resolve after discontinuation. But tolerance is also part of how people sometimes work up to very high doses of opioids and they don't stop breathing. If you then go off of opioids for a period of a couple of months, tolerance is lost. And if you go back to using just what you were using before, it can be fatal. And there's a number of us who've tried to take some action to push the FDA to address some of the highest dose opioids. Oxycodone 680 can literally be a fatal dose for some people if they just take that pill one time. And there's a number of anecdotes of that having happened. This is why people who come out of jail are at high risk of death. This is why detox, and that is going to a residential treatment facility for a few weeks, getting off of meds, and then not entering into any kind of long-term treatment, can be so ineffective and can actually be fatal because you're at higher risk when you relapse. So addiction occurs in only a small portion of people who are exposed to opioids. If we should really use a functional definition. It's when compulsive drug-seeking behavior becomes what motivates all behavior, regardless of the risks that are involved. That is why this becomes a personal property issue as well as a threat to life issue, because people will do anything, commit crimes, whatever it takes to get that next dose. Addiction is related to spikes of the neurotransmitter dopamine in a part of the brain called the nucleus accumbens. Dopamine is the feel-good neurotransmitter, or check that, it's the feel great neurotransmitter. The nucleus accumbens is part of the brain that is wired for pleasure and rewards. It's part of what drives us to want to eat. So it's personally part of the way you keep yourself alive. It's also part of why sex is satisfying. It's part of how as a species we continue to propagate. But there are controls by other parts of the brain, particularly the prefrontal cortex, which I picture as like the control section on the bridge of the Enterprise. And Captain Kirk is up there being a mature adult and telling the rest of the brain what to do. What happens in addiction is rewiring occurs, and what someone has described as the inner Henry VIII begins to take over the brain at the level of the nucleus accumbens. And Captain Kirk can call down, but nothing's going to happen because the response is, I want more drugs. Develops slowly. So I think we have to think of this as a brain disorder, a chronic condition that can take years for recovery to occur. I think if you can draw analogies to Alzheimer's disease, where we know that what makes people with Alzheimer's behave so oddly is not because they're being lazy or because they're just not trying to think harder. I like to say, thinking that people with addiction just need to say no and walk away from that is like saying, well, people with Alzheimer's just need to take that Dale Carnegie course so they can remember names better. Or is it Frank Carnegie? I can't remember. There are people who are at higher risk, and this is an area of evolving science where we don't know everything that we would like to know. There are genetic components that are involved. There are biologic components. There's clear data that people with certain underlying either mental health issues or even organic issues such as traumatic brain injury are at higher risk. There's also the environmental cues, and this would include peer pressure, but also the sort of situation where that spike of dopamine can occur when you just see things that make you anticipate the rush that you're about to get. A patient once shared with me that he's learned to regulate himself when he's getting blood drawn, because that feeling of the metal going through his skin creates the anticipation of what he used to get when he was self-injecting. A question I like to ask people, and I think has become very influential on me in changing my perspective, is what did it feel like the first time you took an opioid? Now, people do become addicted because they're just taking it because, well, it made my knee stop hurting. And okay, I took it a week later because my knee was still hurting, and eventually get into trouble that way. Other people have a very different sensation. I know when I take an opioid, I feel kind of sleepy and, well, it feels good that it stopped hurting, but I want to go to sleep now, and I'm a little nauseous. I think someone in recovery said it best when she said, I felt something I'd never felt before. I felt like Jesus came and gave me a big warm hug. And you've got to stop and say, wow, if you could experience unconditional love and forgiveness like that, doesn't that begin to give you some understanding why people get into trouble with these substances? And unfortunately, that feeling isn't in reality in a pill, but that really began to help me understand why people do things that seem so crazy when they're driven by their addiction. The take-home, though, is that nobody is immune. And when we think of addiction as a chronic health condition, I think it's important to look at it in comparison to other health conditions such as diabetes or high blood pressure or asthma. This was a review put together by Tom McClellan when he was at the National Institute of Drug Abuse. It was actually about 20 years ago now. But he showed that the risk of relapse for addiction is pretty similar for people in treatment compared to treatment for other chronic health conditions. So what do we do for treatment? There's a number of things that can be done. I like this because it's a nice 8-segment checklist, the national standards of care. These were part of the Surgeon General's report in 2016. It's been picked up by a group called Shatterproof, which is led by Gary Mandel, who used to be the CEO of the Westin hotel chains. He lost his son to addiction. And he got very interested in, well, why I spent hundreds of thousands of dollars for treatment for my son. Why did he not get better? And as he learned more about addiction and all the money he had spent on detox programs, he realized that was not addressing addiction as the disease it is. And Gary, being the CEO that he is and having that kind of background, he's been able to engage with CEOs of third-party payers and actually has gotten 16 of the largest insurance companies in the country to sign on to these concepts of principles of care for addiction. I want to point out just a couple down at the bottom there. One is behavioral health care from certified providers, people who have training in providing behavioral health services, access to medication-assisted treatment, and support for recovery in the community. Recovery is not something that anyone should be ashamed of. I want to say a little more about medication-assisted treatment. Since I'm not a behavioral health professional, I know them, I work with them, I love them. Some of them are in the room. But I want to say a word about medication-assisted therapies because there's some, I think, misunderstanding, and also just make sure everybody understands what the options are. The success with abstinence only long-term is only about 10%. That gets up to about 50 to 60% if we look at medication-assisted treatments. I'm a big believer in 12-step program. I think that alone for opioid addiction may be falling short. 12-step is great for alcoholism. Penicillin is great for pneumococcal pneumonia. Penicillin is not great for lung cancer. Opioid addiction is a different disease from alcoholism, and I think it needs to be managed differently. So the options for medication-assisted treatments include methadone. It's been used for over 50 years now. It's a full opioid agonist, meaning it binds to the mu receptor, but you don't have these wide-ranging swings in the amount that is binding to the receptor. So people sometimes can get their lives back with methadone. Buprenorphine, sometimes sold in the form of Suboxone, is a partial agonist, which means you get an effect up to a certain point and then it plateaus off. It's available now in a long-acting injection, which certainly offers some advantages because there is a street value for both methadone and buprenorphine. What I hear from users is using Suboxone is not something they would do to get high. It's something they would use to tide them over to keep them from getting sick till they can get their next dose of heroin. And if they thought they were going to get heroin in the next day, they would not touch Suboxone because it just knocked the buzz off far too much. Now, Trexone's an interesting drug because it actually blocks the mu receptor. And it's also available now in a month-long injection called Vivitrol. And it also has a number of other advantages in that there is some efficacy for treatment of alcoholism. It does not require any special certifications. So methadone, you have to go to a methadone clinic. Your doctor may be able to prescribe methadone in small amounts for treatment of pain. It's not that great a pain medication. It's still legal in this country. But to get methadone for treatment of opioid use disorder, you need to go to a methadone clinic. Buprenorphine, you can get from a physician, a PA, or a nurse practitioner, but that provider has to go through an 8-hour special training to be certified. Now, Trexone is just a matter of providing the prescription. The benefits of medication-assisted treatments compared to other treatments are really pretty impressive in terms of lower relapse rates, lower overdose and all-cause mortality, reduced transmission of blood-borne pathogens, improved social functioning, improved retention in rehab programs, and there is a huge impact on the social service sector right now from opioids. And parents who are in treatment are much more likely to be able to retain their children and be better parents. So I think the summary of treatment is all treatments work for some people, no one treatment works for all people. Here in Alaska, we've started providing treatment to people who are incarcerated, starting with using Vivitrol. Only 2 years ago, if you were stable on methadone and say you had an outstanding firearm charge and got arrested, it was tough luck. You were going through withdrawal once you were in prison. We now are continuing to provide methadone for people who are stable when they come in. I have to make one comment about methadone. Sometimes it's dismissed as, oh, you're just trading one addiction for another. People get their lives back with methadone. You are trading one tolerance, one physical dependency for another, but look at addiction as what it is, the functional diagnosis. So let's talk about prevention. And this is where I think we get the long-term benefit. And we have to look at it in terms of addressing supply and demand. The supply side, I think, is maybe the easier side. One of the things that led to this problem was the influx of prescription opioids into our communities. I think another one of my wake-up calls was when somebody sent to me a memo that went out from the National Realtors Association to their agents saying, advise your clients to dispose of prescription medications before open house, because they realized that it was becoming very common for people to come posing as interested in buying the house and saying, oh, do you mind, I'd really need to use the bathroom. And they would use that as a chance to go through the medicine cabinet and walk out with the opioids. And so I encourage everyone, go home, look at what's in your medicine cabinet, because you may find pills from when your kids had wisdom teeth taken out 5, 6 years ago. I'm looking at my daughter down here because that was the case at my house. It's not your fault, that's right. So one of the things we've done in Alaska is tried to make drug disposal bags more widely available. There's drug take-back programs. Those are great if you can get down to the police station. Not everybody wants to show up at the police station, particularly some of the people we would really like to have dispose of their drugs. This is an example of a bag that was actually donated to us by Mallinckrodt Pharmaceuticals. I just really want to acknowledge, even though they make an opioid, that they donated 25,000 bags to us. I just went knocking on their door once when I was in DC and explained that I'm from a frontier state. It's hard for people to take drugs back. So they even paid for shipments. These have been so popular, we actually have more that we've purchased. We have some here for you to take, and they're also available through the Public Health Center here in Fairbanks. Andy Jones works for me. He's demonstrating it here in a picture on the front page of the Juneau Empire. Somebody gave him very hot water, which I think you're supposed to use warm water, and the bag's getting stiffer and stiffer, and I'm afraid it's going to blow, and I'm picturing Byron Malott back there with activated charcoal all over his face. But that didn't happen, and these can actually be, they're safe then and can be disposed of in the dump. Governor Walker also introduced an opioid bill that addressed a number of aspects of encouraging more judicious prescribing of opioids. We do not want people to suffer. We don't want to limit opioids so much that people are in pain. But clearly, how it's been done in the past is very similar to how antimicrobials have been used inappropriately in the past. And we need to keep the big picture in mind as well as the patient that's in front of us. I think a measure of the lack of standardization is reflected in this slide. This is per capita opioid prescribing in the nation by county. There's more than 6-fold variation. That suggests to me that we don't really know how to use these medications as we should. There's now more and more data on options, and I really want to give a shout out to whoever puts together the program, not just because they invited me, but I know you have a physical therapist, I believe, coming to talk about dry needling, which is a non-opioid, non-pharmaceutical method to control pain. I know you had another lecture earlier from an osteopathic physician that talked about probably some of the physical manipulations that can be done. even with pharmaceutical management of pain, there's very little evidence that opioids are a good way to manage chronic pain. This was a study that recently came out on management of acute pain, comparing just high-dose ibuprofen and acetaminophen, so Tylenol and Advil, basically, with some regimens that involved an opioid for patients seen in the emergency room with severe musculoskeletal pain. Nearly a third of these people actually had fractures, so it wasn't just a little bruising. And you can barely distinguish among those lines how people perceive their pain after a couple of hours. We're talking about leftover prescriptions. This is a slide showing the proportion of opioids that go unused after a number of surgical procedures. And the majority of the pills are never taken. I see a lot of good, positive trends in my surgical colleagues. There was actually an interesting study came out recently from a large surgical practice in Michigan, where they looked at their prescribing, went through how they could improve it, cut it by 2/3, and also found they had no increase in callbacks for refills. So, those are the groups that I think are really teaching us better how to manage pain. I'm a physician, I'm not a cop, and I think it's important to recognize that the opioid crisis is a health crisis, but it is also a criminal justice crisis. This was someone in Southeast really caught my attention when they said, I never locked my door, I never owned a handgun. I do both now. This is some additional data from that study I was mentioning a little earlier. This actually only came out last week, so I don't know if you've seen this before. But let me draw your attention to the linest colored lines. So same format as before, no opioid use, using only as prescribed, misusing, having opioid use disorder, and heroin use. And you can see that as you go up that spectrum of opioid use, you have a much higher likelihood of having had some interaction with the criminal justice system. Particularly among heroin users, nearly half have had some interaction in the past year. This is one of my public health heroes. You guys are public health heroes too, and so gotta be careful here. But this is Marshall, one of the drug dogs. Marshall, as you can see, is a little, well, you really can't see. He's a little gray in the muzzle there, and actually Marshall died about a year after this photo. But what Marshall has recovered here is about 80,000 doses of black tar heroin, those black balls that are there. So interdiction in the illicit trade is also critical. But let's talk about where I think in the long term we'll really have impact, and that's addressing the demand. There's a number of issues that come to play here, including how does the woman I was telling you about earlier have that perception of love and forgiveness that she was only finding in a pill. Somebody sent me this lyric. This is a song from 1972. I was in junior high school then. Randy Newman, and I'm not going to sing it, don't worry. I just can't stand myself, and it takes a whole lot of medicine for me to pretend that I'm somebody else. So beginning to get into the roots of the drivers of self-medication. One of the areas in particular I want to call out is adverse childhood experiences. This is an important part of a number of the behaviors that are detrimental to health. This was based on a study that was done by Kaiser Permanente and the CDC over 20 years ago, and we're still just beginning to, I think, really get our minds around the importance of this in health. Adverse childhood experiences can include abuse, neglect, and household dysfunction. And each one of these items on the slide, each one that you have increases your risk for a number of negative health outcomes. And if we look at it in terms of, well, if we could eliminate ACEs and make everybody's ACE score 0, how much of the use, the problem we have, could be eliminated? For heroin and crack cocaine use, it's nearly 60% could go away. I want to put on an important caveat here. If you have a loved one who is struggling with addiction, it doesn't mean that they've been abused. It doesn't mean they've been neglected. But at the population level, it does mean that there are things we can do to improve health in childhood that will help address this issue as well as other issues. Right now, we're at a time 2 years in a row where life expectancy has declined in the United States. This is an unusual time in our history. Both 2014 and 2015, life expectancy went down by 1/10 of a year. There are 3 drivers that I want to call out on that. One is drug overdose, as we've been talking about, but also suicide is increasing nationally, and also alcohol-related deaths. Not as dramatically as drug overdoses, but taken together, the blue line there shows the number of deaths related to drug overdose, alcohol, and suicide in the United States over the past 20 years. And you can see there are very disturbing trends. And if we look at these 3 together nationally, you can see that Alaska is not in such a good standing, that we have problems with all 3 of these issues. So that's why I like to talk about, even though my background is not in behavioral health, I do like to talk about the importance of addressing adverse childhood experiences, because I think we can spend a lot of resources, a lot of time treating the outcome, which will continue to be something that will not go away until we get to some of the root issues. So to summarize, when we think about public health and health threats in the 21st century here in Alaska, there's a number that are here, things that we haven't necessarily gotten our arms around as much as we have with infectious diseases or with even control of some of the chronic diseases. And it's a changing paradigm. As we talked a few years ago, my background and what got me really excited in medicine and ultimately into public health is how to prevent infectious diseases in that chain of transmission. And you have all these great tools to interrupt the chain so that the host parasite recycle can be interrupted. A lot of the problems we're dealing with today don't fit into a cycle. In fact, I think we deal with a web of cause and effect. An important part of that is substance misuse and addiction. So all of these problems, I think, are going to be best addressed if we look at it holistically. And the opioid crisis is part of what I think is going to change the conversation about health and about public health in our country. So while we haven't seen yet the real turn, preliminary data for the first 6 months of this year in Alaska, I'm going to say, looks very encouraging. There are a number of problems that interact, and that we got to stop sort of wringing our hands, or as a physician, I got to stop saying, well, I'm not trained to deal with that. We have to all step up and respond. And so communities across Alaska have been doing that. I thank you tonight for coming to hear me talk about it. I know it's nearly 8:15, but maybe we could take 1 or 2 questions. And I'll also say it's easy to reach me, jay.butler@alaska.gov, and I'd be happy to follow up with you by email. So any questions? Yes, ma'am.
You didn't speak as much about meth. I'm really concerned about meth in our community. And is there any treatment or rehab for meth and the ability to reverse the kind of rewiring brain damage that seems to occur, and does it matter if they combine it with opiates or alcohol?
That's a great question. So let's start with the treatment. There are not any currently known medication-assisted treatments, so we're really left with psychotherapy, behavioral health methodologies more than anything for methamphetamine. In terms of co-use, it's very common. I don't think we yet have a real handle on how much of it is intentional. We know that some of it is intentional, but right now we're also seeing challenges with the drugs that are coming into the state being contaminated with fentanyl as well. So actually, I agree with your concern about methamphetamine, and it worries me sometimes that we've, at the national level, we're so focused on opioids that we may be missing what's going on with methamphetamine. I do hear that conversation occurring more now.
I just think it's a big part of the crime.
Yeah. Yes.
And just to follow up with her comment, I work with Fairbanks State Association, and in our residential treatment program, we probably have, as I would say equally, if not some cycles more, meth treatment going on than opioid. I mean, both of them are definitely a problem, no doubt, but meth is significant. And I agree that I don't think that we're really addressing that as much as we can.
Yeah, I think your point is well taken. And it's almost like the issue with alcohol. Right now, opioids are the hot topic, and the media wants to talk about, the policymakers want to talk about, people want to fund programs. And, you know, I think our congressional delegation, for the most part, is very open to that broader discussion, that just responding to the crisis du jour is not going to help us in the long term. And I think methamphetamine is a good topic if you want to start talking about other things. Alcohol is a problem, but, you know, that slide I showed on methamphetamine was included intentionally. There's sort of a mirroring in terms of the increase in impact. And that's just looking at deaths. Methamphetamine is not as often fatal as opioids are. So, you know, looking at fatalities, that is only the tip of the iceberg. And I think the comment about the impact of methamphetamine also on crime is very well taken. Yes.
I also work in a residential program, and what I wanted to know is the state doing anything about the adverse childhood experiences that we deal with? Many of the consumers that we deal with, and you've seen the statistics, you know, you have a score of 4 or higher, your chances of having all sorts of, not just addiction, but physical problems. So it seems like, you know, instead of dealing with someone when they're 25 years old and an addict, what are we doing to address the cause of these things? You know, things like COPD goes up way higher. Your incidence with high case rate, incidence of heart disease, cancer. So it seems to me that we're not dealing with really the poor. And yeah, that's a big issue, but what is the government?
Yeah, so when you started that question, I was thinking, well, here's a plug for a great topic for next year. And, you know, I think of a number of good speakers. Actually, as you went on, I thought, maybe you'd like to address that topic next year. That was a very good summary of the health impacts of adverse childhood experiences. So the question specifically was what, I think you actually said, what is the government doing about this? Yeah, so I think the response oftentimes has to be driven at the community level. So there are some similarities to how we respond to the opioid crisis. So the role of the state is to support the communities and also to find out, you know, where are we in the way? You know, how can we get out of the way? Now, getting more specifically into ACEs, a lot of it is still communication and education. In the Division of Public Health, there is a grant program which is primarily driven entirely by federal funds to support visiting home nurses, which is probably got some of the best evidence base for impact. And it actually has a positive return on investment ratio. In terms of some of the discussions that have occurred in state government right now, as you may be aware, First Lady Donna Walker has gotten very interested in this issue and really wants it to be a topic that she can carry forward. I think the discussion that we've had in terms of how we work with other policymakers is to try and reframe the discussion that somewhat like education. We're talking about an investment in infrastructure, that infrastructure being the future Alaska workforce. And say maybe similar to a gas pipeline, we can build it this year, it's going to take a few years. It's going to be a few years down the line till we really see that return on investment. It's going to be similar in addressing adverse childhood experiences. And there is no one single answer, but as I shared with some folks, if anybody was at the Public Health Center, a talk I gave at noon, you know, I remember when I first saw the science on ACEs, and it was very impressive, as you've described. But I kind of, well, too bad there's not a vaccine against child abuse. But we do have more experience now and know what can make a difference. And we're talking about some very broad social issues that lead to adverse childhood experiences and even the intergenerational trauma that occurs. So I wish there was just an easy answer to that, but I think the fact that you're raising that question shows we're making some progress, and that it is a conversation that needs to occur, similar to what the conversation we're having now about how we address drug use in general. Because it again gets back to those last couple of slides with suicide, with alcohol use as well. Okay. All right. So how about last question? Thank you.
So there are the treatment that if you don't know that anybody in your immediate circle that has a problem with opioids, is there a reason why you should take one?
I would say it's kind of like learning CPR. It's kind of like having a tourniquet or having bleeding control training. It's probably a good idea for most people to consider it. These kits are not cheap, so I think if you think there is very little likelihood that you're going to have that interaction, you may not want to take one, but I really would encourage anyone who has a loved one who's struggling with opioid addiction, or even if they're stable on high doses, that may be a very reasonable thing to do. Thank you for that question. So, all right, Gunnar, one last question.
One of the populations that doesn't really get addressed is the elderly, and with their multiple medications that they take. One of them is a pain medication. They can get confused and take too much, and so having Narcan kits for the elderly is a good idea.
That's a very good point. Thank you.
Are insulin syringes the same as the syringes you use at the needle exchange?
Yes, so I don't know if everybody heard that. Are the insulin syringes the same as what's used as in the syringe and needle service programs or exchange programs? In general, yes. The ideal needle is one that is actually mounted onto the syringe because it has less a residual that's left. One of the ways that syringes and needles that have been used before transmit bloodborne pathogens is oftentimes you know you're in the vein if you can draw back and get a little blood. Sometimes people even intentionally rinse the syringe with their blood, and so that's how the contamination occurs. For insulin syringes that have the type of needle that pops on there, there's more residual left. So there's more risk of then blood transmission, but maybe more information than you wanted. But in general, it's a similar type of needle and syringe. While we're on that topic, just anecdotally, one of the benefits of syringe and needle service programs is that then becomes a place where used syringes and needles can be taken back rather than being left in the parks and various places around town. So, thank you very much, and